Hello all dental surgery nerds. My name is Fatima Mashkor. I'm an assistant professor at the Oral and Maxillofacial Surgery Department at the University of Pacific Arthur A. Dugoni School of Dentistry. Today we will present a surgical extraction case of number 17 done at the predoctoral clinic at University of Pacific. Please be aware that this video is meant to supplement and not replace proper instructions and guidance when performing such a procedure. The tooth in this case was indicated for extraction due to a history of pain and pericornitis. For a detailed guide to wisdom teeth extraction indications, please refer to the white paper on third molar data published by the American Association of Oral and Maxillofacial Surgeons. The link will be posted below. The patient's medical history was non-significant and there were no contraindications to proceed with the surgical procedure. This tooth is categorized as Class 2A under the Pell and Gregory Wisdom Tooth Impaction Classification System. Prior to the extraction, anesthetic was given for patient comfort. For specific technique guides, refer to the card on the upper right of the screen. In this case, 3.6 ml of 2% lidocaine with 1:100,000 epinephrine was administered through the inferior alveolar, buccal, and lingual nerve blocks. More can be given as necessary, but please be aware of the maximum dose for 2% lidocaine, 1:100K epi, which is about 4.4 milligrams per kilogram. As with all extraction and surgical procedures, placement of the throat pack is absolutely necessary to prevent swallowing or aspiration of any foreign objects. Placement of a flap is necessary for visibility and access to the wisdom tooth. A sulcular incision is made with the number 15 surgical blade starting from either mesial of the first or second molar. The length of the flap will depend on the impacted third molar and reflection of a tension-free flap. A hockey stick or a distobuccal release incision is made distal to the second molar, keeping aware not to violate the lingual retromolar tissue. This is important to avoid damage to the lingual nerve, which is located about 10 to 14% times above the crest of the lingual plate. A full-thickness mucoperiosteal flap is then reflected with the pointy end of the periosteal elevator for adequate visibility and access. Due to the history of the pericornitis, the flap had scar and fibrotic tissue, which made the elevation of the flap cumbersome. Once the site is exposed, the clinical crown must also be exposed using either a number 8 round surgical burr, 702-703 fissure burr, and a surgical drill. Depending on the type of impaction, the specific approach may vary. In this case, the clinical crown is visible, so we proceed with troughing the buccal aspect of the ramus. As a dental student, the concept of a buccal trough is sometimes hard to grasp. I tell my students to imagine they're cutting a crown, and the technique is similar to doing a chamfer technique. Difference is you're cutting the buccal aspect of the mandible without touching the crown. The width of the buccal trough should be wide enough for a small straight or curved elevator head to fit in, and the depth should ideally be below the CEJ. After creating a buccal trough, an attempt to elevate the tooth is made. In this case, the tooth was easily mobilized with an elevator and did not require sectioning. When using an elevator, one has to be careful to choose the right size, a small, medium, or large. Always make sure when elevating to have a finger rest to prevent slippage and damage to adjacent structures. If there is no mobility, then sectioning of the crown and roots should be done. Sectioning will depend on the type of impaction, angulation, and the roots. It can be done either buccal lingually or mesiodistally. Avoid going through the whole crown to prevent lingual cortical perforation because of the close lingual nerve approximation. After the tooth is removed, inspect the socket to ensure no remnants of tooth are left behind. Curettage of the site is done to remove any granulation tissue and dental follicle associated with the impacted third molar. It is imperative at this stage to irrigate the site thoroughly with sterile normal saline, especially underneath the periosteum buccally, to prevent subperiosteal infection. No footage was obtained for the placement of suture. With that said, a 3-0 chromic gut was placed to ensure hemostasis and proper healing of the extraction socket. The placement of the suture will depend on the type of incision. In this case, the sutures are placed on the distal papilla of the second molar and on the distal buccal release incision. When suturing the distal buccal release incision, only bite the mucosal layer with your suture needle. Do not take a deep bite of the intermuscular layer. This is to prevent trismus post-operatively. This marks the end of the video. Please do not hesitate to contact us if any questions, and remember the rule of surgery: see one, do one, and teach one. Thank you.